everyone, and welcome to PCR London Valves 2023. My name's Edwin Ho. I'm an interventional echocardiographer from Montefiore Medical Center. That's in New York in the United States of America. I'm joined by two of our friends here. So we have Marta Sitges. She's from the hospital clinic at the University of Barcelona. And then Victoria Delgado from the Hospital Can Ruti, also in Barcelona.
Thank you.
So today we're going to be discussing imaging essentials for mitral valve intervention. We're going to be focusing on pre, intra, and post-procedure imaging. And I'm going to have a series of questions that'll hopefully launch some good discussion. So Marta, maybe I'll start with you. So if we're thinking about the pre-procedure imaging and screening, what are the modalities that you usually look at and what are you looking for?
Well, I think that the most important modality is echocardiography. It's our first line tool. So with that, most of the times we can tell the whole picture. So we can understand the severity, the hemodynamic impact of mitral regurgitation, and also the underlying mechanisms, which are important. So with this information, if we are planning for repair, probably the information we've got with echo is enough. If we are thinking on other procedures such as transcatheter mitral valve replacement, we will probably need to add CT. I think these are the most important modalities. In some patients, maybe for quantification, cardiac MR may be of help in some doubtful cases, but our regular practice, I could say, is 95% of patients echo. Some of them, when you're planning transcatheter replacement, CT, and in very few, when you have doubts, cardiac MR.
Great. And transesophageal, transthoracic, both?
Yeah, that's a very good question. I think that mastering transthoracic echocardiography is very important. And currently we have systems that they have 3D capabilities. So actually you can get, if the image quality is good, you can get a lot of information from three-dimensional echocardiography with biplane views. So you can kind of recreate what you will have during the procedure. Transesophageal echocardiography is key practically to decide whether you go in or not to a transcatheter intervention, because you are the eyes of the interventionalist. For surgery, they are going to see themselves directly, but still they also like to see which is going to be the anatomy of that valve and what they are going to find. So I think in that case, when you have already the indication that an intervention is needed, then you do a transesophageal and you use the full spectrum of all the modality that you have within transesophageal echo to give a precise diagnosis of the anatomy and mechanism and severity, as Marta was saying.
Yeah, I fully agree. And that's a great transition actually to questions about actually intra-procedural imaging. So what do you think are important skills that an intra-procedural imager needs, and what are some of the key views that you use?
I think that the intra-procedural imager or the interventional imager needs to know is about the device, how it's implanted, which is the access, and how you integrate the information that you are going to provide with echocardiography, also with the imaging modality that the interventional is more used to, that is fluoroscopy. So knowing where your transesophageal probe is in relation to the fluoro that they are seeing is very important. You also need to know which are the standard views that you are going to use in order to guide that procedure, and for each procedure, mainly we are going to work with the biplane views, but you can alternate with full volume 3D views. And then there are the other techniques that is, for example, fusion imaging, where you can have the fluoro fused with the echo, and that can improve or make the communication easier with the interventionalist and the interventional imager.
Yeah, great point about communication, and during the case, everything that happens and needing to evaluate all the different steps. And then when you're in a case, Marta, how do you evaluate if the result is good enough?
Well, I think that's a very important point. So you really need to know the procedure, as Victoria mentioned, and knowing the potential hazards. No? So you really need to be very systematic in this sense. I mean, everybody wants to leave the cath lab, and you have to make sure that everything is correct. So from depending on the procedure, but residual leaks, everything, check gradients, check leaflet insertion. If you're doing TR, check pericardial effusion. Always think beyond the mitral valve because there are potential hazards also. So I think it's very important to follow a pre-established systematic, not to forget anything.
And what happens when you have, for example, multiple jets? Do you use any other sort of tips and tricks to get around that?
You mean for multiple residual jets?
Yeah, to try to understand severity.
Well, I think when you have residual MR, the most important thing is to establish what's the underlying mechanism leading to that residual MR. So if you can treat, what's the direction? If we have a more straight, small jet, it's not as important as we have a very eccentric jet, maybe due to residual prolapse that you need to treat. So establishing what's the cause of that residual MR is of most importance. And if you have multiple, you have to do one by one.
Excellent points. Yeah, I agree. And then maybe Victoria, coming back to you, what about follow-up? What are you usually looking for? What's your follow-up imaging plan for these patients?
So what Marta already laid out in terms of how to assess the result is the very important starting point for the follow-up. So you check that the device is well implanted and there is no detachment in case we are, for example, in an H2H repair, that the function of the ventricle improves or the ventricle reduces, or there is a remodeling of the atrium as well, so that there is some shrinkage, because then you are showing that there is a benefit from that therapy, but also potential complications later on if there is any. And always listening to the patients, because what you are going to see on the echo needs to match as well somehow with what the patient feels and make this correlation.
Great. Anything different from your end?
No, I think it's important to, as Victoria mentioned before, to understand the procedure also, because you can be aware of the potential complications also. They are very infrequent, but they exist.
Totally agree. Great. Thank you both.
Thank you.
Thank you very much.